Show. I'm Dr. Kasey Holland, the host of our show. The Made to Heal show dives deep into the hidden obstacles that keep people sick, stuck, and searching for answers. From chronic infections and viral reactivations to environmental toxins, burnout, emotional stress, and nervous system dysregulation, we explore the complex roots of illness that conventional medicine often overlooks. Through honest conversations, patient stories, and interviews with leading experts in functional and integrative medicine, you'll learn what it really takes to recover your energy, clarity, and vitality. This isn't another surface level health podcast. It's a journey into the real mechanisms of healing, empowerment, and transformation. Because you weren't made to just struggle, you were made to heal and thrive. Thank you for joining me on the Made to Heal show today. I am very excited that we have Dr. Paul Anderson joining us today. Thank you so much, Dr. Anderson, for your time and expertise that you're going to share with us. Dr. Anderson is a recognized educator and clinician in integrative and naturopathic medicine with a focus on complex infectious, chronic, and oncologic illness. In addition to 3 decades of clinical experience, he also was head of the interventional arm of a US NIH-funded human research trial using IV and integrative therapies in cancer patients. He founded Advanced Medical Therapies in Seattle, Washington, a clinic focusing on cancer and chronic diseases, and now focuses his time in collaboration with clinics and hospitals in the US and other countries. He is also a former educator, professor of pharmacology and clinical medicine at Bastyr University, and chief of IV series for Bastyr Oncology Research Center. He is co-author of the Hay House book, Outside the Box Cancer Therapies with Dr. Mark Stengler, as well as co-author with Jack Canfield in the anthology Success Breakthroughs and the Lion Crest publishing book, Cancer: The Journey from Diagnosis to Empowerment. He is also co-author with Doctors Osborne and Carter of the IV textbook, A Scientific Reference for Intravenous Nutrient Therapy. So as you can see, Dr. Anderson has an immense amount of knowledge and wisdom to share from us. And today I've actually asked him to join us to talk about one of his most recent research articles on long COVID. So thank you for being here, Dr. Anderson. Let's start with just hearing your experience with COVID and how you got into this space where you are, where you're writing papers and reviewing them on treatment for long COVID.
Yeah, well, first, thank you. It's great to be doing the podcast with you. I think, if we rewind back into the earlier days of COVID as an infection, um, we started to see really early on that there was a post-COVID type of a syndrome. And I think for those of us that do chronic illness care, it was not a surprise because we see lots of other infections that are more complex and have more effect on the immune system, have post-infectious, problems. In earlier days, when that first started to happen, it was a little shocking, I think, for the major medical community because in the mind of, big medicine, we might call it, there are very few true post-infectious illnesses, which we know is not really true, but in their mind it is. So what we started to see, though, was a pattern that I'd seen before with lots of other infections with some interesting and unfortunate immunologic features that were even worse than some previous infections. So I started to recognize that pattern in people and in either patients I was speaking with or in clinicians that I was mentoring to help with their patients, started to see the pattern repeating over and over. And that's what became, what we know now as long COVID or post-acute sequelae of COVID. And then we started to add on more understanding and knowledge about the level of spike protein and how much, in addition to just the infection creating its own problems in your body, the level of spike protein that may or may not be leaving your body, creating its own other issues as well. And so it was a lot of just seeing an old pattern resurface it was pretty clear, that COVID was something not certainly new altogether, but it was a different kind of infection, and it became pretty clear that it was going to affect people. So the the review paper that I wrote is a little bit started, prior to COVID, just in seeing other infections create problems for people, and then watching these patterns and the research go on throughout the heavier, COVID infection years. And then, as recently as last year, it was published toward the end of last year, newer data coming out about the fact that there's this other layer of spike protein issue that can go on to aggravate the problem. So that's the short version of what got there. When I turned the paper in, so the paper that you're referencing will give a link to has 139 references, so it's very well backed up. And a lot of that is because there's a lot of data that people don't know about. I try to put it all in one place. The other thing is the publisher, it's very long. You've read it. It's a lot. And the publisher really wanted to split it into a part one and a part two. And I said, well, the problem is if you do part one, that's all, how did we get here? And what are all the problems? And part two is really, what do we do about it? So I talked them into putting it all out as one really long paper. So that's kind of the short version of how we got where we're at.
What infections would you say looked the most similar to post-COVID where you were seeing patterns? Was it, flu, or were there specific infections that were more similar?
Yeah, y- you could say influenza, you could have a similar pattern, but in general, I mean, depending on what someone comes to influenza with, you usually don't see post-influenza syndrome be as bad as long COVID is for other people. So unless a person had a bunch of other problems going into it, which also makes COVID worse, but if they get influenza and they're otherwise reasonably healthy, you don't see this immune shift that goes on in most people, at least with most of the influenzas that we've seen go around. Now, there are certainly, we know from the earlier, turn of the 20th century pandemic with the so-called Spanish flu, there was a lot of post-influenza syndrome there that was a lot of autoantibody development in the brain and other stuff like that. But most influenzas don't do that. The infections that it started to remind me of, COVID, when you got to the post-infectious state, were things in the human herpes virus family, especially Epstein-Barr and cytomegalovirus, and then some of the other higher level HHVs, because they can have an immune shifting effect once the infection is there. They are also not um, dealt with in many people acutely like influenza is. So Epstein-Barr and its cousins certainly were something that started to look really familiar here. And then which didn't surprise anybody, we started to see there was a lot of co-infection with Epstein-Barr, cytomegalovirus, and COVID at the same time, which wasn't great. But the other ones actually were things like Lyme and the Lyme co-infections, and I think more, which of course most of that's bacterial, although there's some other things. It's not so much because of the primary infection, but because of the immune shifting that it does. And so, one of the things I think that it's sort of good timing. I was just reading all of the latest autoimmunity literature and doing an update for that for teaching. And one of the things that keeps coming up over and over, and this has been known a long time, but if you have an infectious agent that does anything with furin cleavage sites, which are a part of a binding molecule site in your immune system, you are more likely to have downstream immune disruption and then potentially autoimmunity and other immune disruption develop. Well, we learned really early in COVID that was one of the pathogenic ways that COVID became such a problem. And so, what I try to relate to people who are, especially if they're really sick and feeling like am I ever going to get better? Um, COVID, like some of those other infections, has an even more aggressive ability in people, especially with certain genetics and underlying health conditions and other stuff, to shift your immune system to be pro-inflammatory too long, and then that can create a lot of downstream problems. And so, what I would tell them is if you get kind of a standard influenza, you get really sick and you get a high fever, but then there's a termination of that. Your body goes in and says, we've done enough fever, and it comes down. And then you have a resolution phase, and you might have a few weeks of fatigue and other things, but then it generally goes away. With COVID and some other types of infections that are similar, the immune system gets confused. And so you get this upward arc in inflammation, and then it kind of just burns along longer than your body is designed, your immune system is designed to deal with it. So then you wind up with having a confused immune response that's not having a resolution phase. And that's really one of the early problems that, we saw with, you look at the early variants of COVID where people were dying. It was in that phase where the inflammatory cascade was not going down. And then when the later variants of COVID got more, survivable, et cetera, it was still during that phase where the immune dysregulation happened. And then not all of long COVID is that immune dysregulation, but a lot of it is. It leads to other stuff.
Yeah. So what I'm hearing you saying is that there's the obvious, don't feel yourself after you have the flu and your body has gone through that.
Yeah.
That's that's normal. But then there was this added spike protein, and your paper does a really good job of explaining that spike protein and kind of where that comes from and how it
Right.
stays. So can you kind of explain that? Because now we also have spike protein from the actual COVID infection, and then we have this other layer of spike protein from vaccination. And based on what I see with my patients and what I've learned from you is those pretty much are doing the same thing with that immune dysfunction. Is that correct?
Yeah, a big picture, yeah, that's a good way to say it. And again, there's a fair amount of individuality to this. So anything we talk about in regard to spike protein, there's a wide variety of individual experience. So I'm going to talk about kind of the middle of the bell curve, the majority of people, but there's always people who have either a lesser or a greater, reaction, let's say, or something like that. But at its core, the spike protein from the infection and spike protein that's generated from vaccination are doing the same essential immune activities, let's say. The issue that can come up, and we discussed this in the paper, is you can have what they now is emerging term called spikeopathy, which actually does appear in some peer-reviewed literature. It's not just sort of an internet thing. It's a real word. Um, but it's trying to describe this idea that you have a spike, which is not unique to SARS-CoV-2, but that's the virus we have right now that makes spikes. So that's the one that most people have. And so you have this in your body. And if it's there too long, or if you have too much of it around, the body is constantly being sort of assaulted immunologically. And then you get this downstream inflammation and immune confusion that leads to a lot of the long COVID stuff. So at its core, you could say a spike is a spike, doesn't matter where we got it. There are now, and this is something, of course, that took some time to do studies on and things. There are now data that would show that in many, not all, but in many people, spike protein from the infection has a big increase when you get infected, and then it tapers off in usually months, after. Um, initially they said, well, if you get in a vaccine, the spike will do the same thing. It'll go up and then it'll taper off. And what we know now is we have studies showing that spike from vaccination can last much longer. Okay. Now, you could look at that and say, well, if that's what's keeping me, immune from more COVID, wouldn't I want it there longer? Right. And to a degree, there's an argument to be made there. The problem is that, unlike other things that may come downstream from different vaccinations, if you're still making lots and lots of spike protein due to either vaccination or infection, but usually now it would be vaccination, you're going to have this kind of continuing immune deregulation and inflammatory shifting that's not normal to your body. And in the paper, I quote one or two studies, and there's more now. But I think we have from vaccination, and there's a way with labs to tell the difference, that we find in people, 150, 250 plus days, after. So it's not really it'll be gone in a week that we kind of were first told when we were doing the vaccines. So, but what I try and do with folks is, it's like, we all decided to do whatever we did for treatment or prevention or whatever with COVID. If you have a problem now, you can't go back and relive your life and, do or undo something. So really what we need to deal with, if you have like a long COVID picture or anything in that thing, is, yeah, it's good information to know, did you have vaccine plus COVID? Did you just have COVID? Just have vaccine, whatever. Now we got a problem. We can't undo the past. What do we do about the spike that is there? Right. And again, highly variable. There are people with really bad long COVID who never got vaccinated. And I do YouTube videos for the public, and sometimes I'll say that, in the public forums, and people get very upset and say there's no long COVID, and, people who just had the infection, which is not true. That there's long COVID and people who just had the infection, but also there's this layering effect that can happen. And let's say you're having a bad time, and then now you've got a secondary spike production from the vaccine. You sort of get this long burn. And again, those downstream immune changes then open you up to more sensitivity to things that would otherwise your body could have dealt with, underlying issues, and more likelihood that you're going to either reactivate old infections that are already in your body, or be exposed to something that you'd normally fight off and you won't fight it off. So then, that's really where a lot of the long COVID trouble comes from.
Yeah, I think also defining long COVID, you did a really good job in your paper, but there's so many symptoms associated with it because of the individuality that you're talking about. So for people that, think they have long COVID or, are still really struggling and they want to get tested, what labs can we point them to that can help gauge if this is something that needs to be addressed? Because, and this is for providers too, because a lot of patients that I see come to me and they'll say, well, I actually asked, so and so to test me because it seemed like all of this started after I had COVID or after I had a vaccine, and their doctor just wasn't aware. I think it's becoming more common knowledge, but you do a really good job in your paper of explaining the different tests that we can order. So if you want to go into that so that anybody listening can, write it down and say, this is the test I want.
Yeah, and I think where a lot of the provider confusion comes from is, number one, like we talked about, in the mainstream big, you know, take all healthcare providers, put them in one pool. It's very rare in that pool for providers to deal with chronic infectious illness. So that's sort of a small piece of the pie. So it wouldn't be naturally a thought that they would have that, oh, this person's having what looks like long COVID. I should test for that, right? It's sort of like that's just not, on the radar. Also, it's something that we do, those of us that do chronic illness a little bit more, but again, that's such a minority of people. So what I usually tell people is if you have enough symptoms and it appears to you that you were one way before you had COVID or the vaccine or both, and then after that you have different health that is not what you want, if you have enough of that going on symptomatically and changes in your, ability to do what you want in your life and health, then you're seeing a healthcare provider, you should have a baseline test to see if you have a small, medium, or large reaction to spike protein. Is the test perfect? No, no test is. But as a baseline, it would be really good to know because as you've seen in practice, there can be people with all these symptoms, and one person may have very, very high spike antibody, and more of their trouble might be that. And then another person may actually have very low spike antibody to start with. Their trouble may be all of the other comorbid conditions that we can talk about later to deal with. So it's just a way to get a picture in the beginning. So what I'll usually recommend to folks, and in the paper it's all, lined out better, but you want to do something to benchmark how is my immune system dealing with the spike protein. And then you also want to benchmark your major health marker labs, looking at just broadly, how is your body doing? That could be some hormonal things, that could be other infections, that could be, liver and kidney, could be all sorts of stuff, right? So in the world of the spike protein, and I have it written down so that I say the right test because there's a few different tests and we want to be clear. The SARS-CoV-2 semi-quantitative total antibody, spike. Okay, so it's S protein semi-quant. What that means is, so a quantitative test would be giving you a number of a value. They're arbitrary units, but it's a value. This is where you can kind of come up with it's a small, medium, or large response I'm having. So if it's usually in, the hundreds or lower, that's a really low response. If it's in the thousands, that might be recent disease or disease plus vaccination. And if it's in the high thousands or, even 5 digits, that's normally ongoing spike protein production from vaccination. There are people, you could flip that around. There are people who break that mold, but at least you get a number that's sort of small, medium, and large. So semi-quantitative total antibody spike. There is also, this is less done, but just it's in the paper because this is how you do research to figure out, or even in a patient, is it native to the infection or is it just from the vaccination? The infection has a nucleocapsid, which is kind of holding the virus together. And so there's a N protein also, and you can test for the N protein. And this is a qualitative test. It's just, is the N protein there or not? The reason that can become important is if you have a lot of N protein and S protein, it probably means you were infected fairly recently. And with the variants that are around now, you might have been reinfected and not really know it. You could feel like you had a cold or something. The other thing, though, that they do in research is they will take the people separately who'd have zero N protein and it's all S protein. And that, in that setting, it can only come from the vaccination creating, ongoing spike. So the semi-quant S protein is the one you want. We usually get that through LabCorp. The other big lab in the US is called Quest, and I have not checked to see if they have that particular test or not, but it's readily available. The N protein is done less often, but that's if someone really wants to know, do I have lingering, infection going on as part of my problem? So that's that test. And then if I was going to see a patient fresh and they came in and said, something's not right since I had whatever COVID related thing go on, whether it's infection, vaccination, or both. Uh, as a benchmark, I would do the spike semi-quant, and then I would do the other health markers to look at how is your body doing generally separate from COVID.
Yeah, you explained that really well. I think, it's that immune response that we're gauging. It can be confusing because it's the same type of thing with things like Epstein-Barr virus, where, well, this is a past infection, but when that response is really high there, you know, your immune system still has that burden. And so I think that as time goes on, there'll probably be better ways of testing than maybe just an antibody response too, because that's also a whole.
Just so people know, and I put it in the paper, there are in other countries, you can measure the actual presence of the spike, not an antibody. And that is a better way to do research because it's a way to actually know, you don't have this sort of mirror image, which is an antibody test. You have a direct image. And there are ways to get that test done and, send it to Europe and have it, have it done. It's expensive. It would be a lot nicer if they would just do the lab here in the US so we could do it. But kind of, again, keeping in mind the limitations of an antibody test, it's still a pretty good way, like I say, to see is it a small, medium, or large immune response. But just so people know that those other tests do exist, they just don't exist in North America.
Yeah.
Yeah.
Okay, so say somebody gets their spike protein antibody test back and it's really high. I know, well, I've seen in the 20,000s now.
Mhm.
Then, and I think the other thing that is important is typically with that response, they're symptomatic, right? Like it's not like we're it's not the symptoms
Yeah.
typically match when they're that high. So
Yeah.
let's hear your review of what options there are for specifically the spike protein. And also I just want to highlight that we're talking about a very specific piece of this long COVID picture right now because, like, and you can reference this paper in the show notes anytime, but Dr. Anderson also talks about all different comorbidities that need to be addressed. So we're not saying that, hey, just addressing the spike protein is going to fix everything, but it is a piece of it. And so but I know that those are very much newer therapies. And so I want to highlight those and have listeners be able to hear that straight from you so that they know, their options and what's out there and what's available. Like you're talking about how there's a lab in another country that we don't have yet. I think it's good for people, especially that are sick and just want to have hope and know what's out there to hear what all therapies, but these therapies that I'm asking Dr. Anderson about are specific to that spike protein that we just talked about.
Yes. And thanks for making that distinction because in my experience and the experience of everybody, clinicians I've worked with, if we don't address all of the other comorbid problems, the other health issues that stack up, it's really hard to get the person better. And so if we just focus on the comorbidities, then the spike is still a problem and vice versa. But because the spike issue is its own sort of little microcosm, there's a few ways to think about what do I do with that? Okay, the spike part. So exclusive of all the other problems you can get with long COVID, the first thing is testing at baseline to know is it a small, medium, or large thing. So somebody's got symptoms and they've got, 1 to 5,000 or 20,000, like you said, that's at least a part of the problem, right? Is this large spike burden in the body. If it's not there or it's a few hundred, it's probably, you would go right to the comorbid things and start treating them, as well. But in people, especially they've been treating all the other things, they've been working on, their whatever their determinants of health are, and they're still sick, then testing and finding out, gee, they got a S semi-quant, in the thousands or tens of thousands. You got to do something about that. The first thing is there's two pathways. I mean, there's multiple, but there's two pathways that you really want to work on to deal with the spike protein if that is the big part of your problem. So the first one is, yeah, because obviously if you're making a lot and it's floating around in your body, if you can keep it either bound so that your immune system recognizes it and eliminates it or blocks it from entering the cells, that can really decrease the symptoms a person's having because they're not going to be having the S protein go and create problems where when it enters cells and it creates its own immune response in the cell. So when we're looking at the blocking and binding part, there's some drug therapies and natural therapies, and usually we make a combination of them because it works better. And there's references for these in the paper, but one of the reasons that ivermectin works, and people will say, well, why would taking an anti-infective drug, when the infection is gone, all of a sudden I feel better? What's it doing, right? Big picture, drugs like ivermectin are not only anti-infective, they're also immunomodulatory. And so the immune dysregulation the spike causes can be partly combated by something like, say, ivermectin. But ivermectin also now has been looked at, and it has the ability to stop the spike from going into your cells, which is very, very important. Okay. Then there's some common things that we might use in the natural world, like the flavonoid quercetin, uh, curcumin, which is the ubiquitous herb. Everyone seems to be using it. Other flavonoids like in luteolin and things that you might see used like in mast cell problems. Those are very good at helping either blocking or binding spike protein. But the other thing is there's a herb most people have heard of called milk thistle, and we'll often use milk thistle along with ivermectin because they both do multiple things. So they're not just sort of collaborating with the binding and blocking of the spike. The milk thistle is also going to be very protective for the liver with the other treatments you're doing. It's somewhat anti-inflammatory, so it's going to be a really good collaboration. So, for example, in the paper, I use the example of using ivermectin and milk thistle together. But that's why those would work. Then there would be, how do we degrade the spike protein? So if we're blocking it and binding it, good, but we still have it floating around. And let's say it's a situation where you're one of those people, after vaccine in the studies where 100, 200 days plus you're still making spike protein. Be really nice to break some of that down. One of the universal things in long COVID that has to be dealt with is increase in clotting coagulation problems. So we often use an enzyme such as nattokinase for that. Well, it turns out, and there's references in the paper about this, but it turns out that enzyme therapies also, which kind of makes sense, enzymes will break proteins down. Turns out that nattokinase and its relatives in the enzyme family will also break down spike protein. So that's again a 2-for-1 benefit. We usually have people on nattokinase to help so they're not clotting as much, because many people with long COVID, their blood gets thicker and they clot too easily, which we don't want. And then you get microclots, and that's bad everywhere. So you put them on nattokinase. Well, so if you've got some combination of like the ivermectin and milk thistle coming and working on binding and blocking, and then you have enzyme therapy like nattokinase, et cetera, breaking it down, that's two really good ways into the problem, like for a chronic approach to getting rid of the spike. And people say, well, I'm going to make more. Yes, you are. But if you don't start blocking it and breaking it down now, you're just going to keep making more and keep confusing your immune system. So that's sort of like the internal things you can do. And it's a little more complex than that, but that's kind of the idea there. Let's bind it and block it, because that'll help your health. Then let's try and take it apart with enzyme therapy. That'll help get rid of it. And eventually the levels do go down eventually, regardless of how you got them. The other side of the coin then is, and this is something that I'm currently involved in research around, it's human research, so it's very exciting and we're waiting for data and all that. But there are ways to get rid of proteins we don't want that are in our blood. Okay. They are medical therapies. They're very high level medical therapies. There's very kind of intense. But by the same token, if a person has a lot of something in the blood they don't want, we've looked at this in the setting of mycotoxins from mold, microplastics. There's almost nothing that gets those out of your body, other toxicants and other proteins we don't want in the blood. And so what we do is a process. The umbrella is called apheresis. It's a process done for many reasons, usually in hematology. The therapy that we find the most useful under the umbrella of apheresis is a plasma exchange. So the total plasma exchange, usually they call it. So PE or TPE. And what happens is this, like I said, it's a very intense medical therapy. As part of the research, I've had it done on myself to see what the patient feels like. Also, I'm old and toxic, so why not get some of the junk out of me, right? But it is an intense therapy. So you use essentially a cell separating dialysis unit, and you have a line in one arm going into a vein that is taking the blood out, and it runs into a very large complex machine. And then there's a centrifuge in there that spins the blood and separates the plasma, which is the non-red blood cell, white blood cell component part. And it takes that and puts it in one compartment, and then it returns your blood cells, so red cells and white cells and stuff, back into you, right? While it's doing that, you have to then put a buffer of albumin, which the major plasma protein that you have is albumin. So there's a liquid that's usually a 5% albumin solution. So that's going in back into you with your original red blood cells and white cells. The plasma that is removed from you is literally leaving your body. Okay. So we have to replace it with the albumin. The amount of albumin that you get depends on your body size, really. There's a calculation, and computers are involved and stuff, so it's all very safe. So a larger person like me, there may be, a few liters worth going on. A small person might be, liter or less, depending. So you might say, well, how is that helping? Well, if it's a protein in your blood and you can separate your cells, because we wouldn't want to take all that blood out of you. You need your red blood cells and stuff. So we put that back in. But if we can separate you could call it the clearer part of your blood, the plasma, and take the proteins out and replace it with essentially a neutral albumin that would go back in you, then we can remove a layer of the proteins we don't want in there. If it's the protein directly, like a spike protein, or they do this with other protein-based sort of molecules in certain illnesses, it gets it out of your blood. Well, how does that help long term? Well, the first thing is it takes most of what was floating around in your system, and it's just gone. The next thing is the natural response of your body. So you recover, and you've got the albumin that was given to you, and then your red blood cells, and then we took away your, you call it your bad plasma, then your body will say, all right, well, it's time. The liver and the bone marrow will speak to each other, and they'll push a new layer of, new proteins out and all of that. And so then the next layer of either toxins or bad proteins you don't want or whatever come up. So in plasmapheresis, what we're finding is the interval doesn't have to be real close together. You can do the initial treatment, and then between 4 and 8 weeks after, you can do your second treatment, because plasmapheresis has to be done in a center that is very highly trained and they have the right equipment for it. It's not on every corner. There's more and more of it going on because people are realizing the benefits, but it's, you still have to do that. So, for example, when I was doing this and I wanted to see what it was like doing the research on folks, I traveled to get mine done, but I only had to do it, I'd go down and get it done and then fly home. And then 2 months later, usually go and do another treatment. I look at plasma exchange, like TPE, apheresis, as the only way to lower really high levels of spike protein, if that indeed is what's going on in the person. You still have to do the binding and blocking and the enzymatic, breaking it down. But if the person's already doing all that and they're still really symptomatic, then some sort of plasma reduction is a very necessary thing. I will say, and the research was not done with COVID, but it was done with toxins, and the mechanics are the same. It was a study done in firefighters who are, exposed to all sorts of toxins, and they got a plasma exchange like effect by just donating plasma. It's a smaller amount of, obviously, smaller amount of plasma going out of your body, but you can do it more frequently. And they, over time, somewhere I think it was 11 or 12 donations, and they really lowered the levels of the toxicants that were in the bloodstream. Same thing would happen with the proteins that you don't want. So a removal process like plasma exchange or a plasma donation repeatedly done, probably the most effective. What we what I'll tell you from not just my experience, but our experience with patients in the study, is the first two, if you do plasma exchange like a TPE, the first two are a little more, you really feel them a lot more because they're moving the most toxins and toxicants out. And so what we find is that you really want to have treatment in between. So in the case of spike protein, that would be the binding and blocking and the enzymes, but also things to keep up like your antioxidant status and just general nutrition to help you, make the new blood. After the second treatment, usually the levels of toxicants are going down, and it starts to become, a little easier to deal with as you feel it. So those are sort of like the outside treatments that, you could do. But if because this is going to go to people all over, you can search TPE, and if you just put TPE and then plasma in your search, you'll find centers that do this, and they're generally outpatient centers. It is done in hospitals for emergency purposes, and like I said, hematology, but you don't need that for this particular purpose. You would need a plasma exchange center that's doing outpatient work. And there's more and more all the time. I think just since I started getting involved in the research a couple of years ago, I think it's gone from a literal handful, like 10, 20 centers in the US, to now, over 100, and there's more all the time. And it's driven by the fact that people are so affected by either, spike protein or toxins or whatever.
Yeah. Wow. Well, on that note, I think we probably all have a lot more questions coming up about this but yeah, I mean, I think it's amazing that we have this therapy coming out for people that are really suffering and that have those high spike protein levels. Because we are out of time with Dr. Anderson today, I want to make sure that I share just some resources. You can also follow his YouTube channel where he talks about a lot of the comorbidities and things that we didn't have time to dive into that are also part of long COVID. For providers, you can also become a subscriber and meet with his webinar each month, learning and getting continuing education. And that is extremely valuable. And also, he's on social media. But I want to make sure that for people that are listening right now and they're like, okay, so I think I need plasmapheresis, or I think I need this, or I think I need that, just to provide resources of his YouTube and other teachings to kind of connect the dots on this. Because, like I said before, what we're talking about is really specific to spike protein. And gosh, that's what's so hard about long COVID is there's so many other systems that are impacted, like your adrenals, your thyroid, that we didn't even touch on. So making sure that you have those resources for you. And I just want to ask Dr. Anderson any final closing thoughts that he has that he wants to make sure people know in regards to this or health in general.
Well, that could be a really long answer, but I think in regard to long COVID and spike protein issues, if you haven't, even though the test is not perfect, if you haven't had a spike protein semi-quantitative test done, get a benchmark to see, and that will kind of tell you the bigger the number is, the more likely that's a bigger piece of the problem, the bigger piece of the pie of your problem. So that would be number one. Number two, some people are, maybe without knowing it, are already doing things like the degrading with enzymes and blocking with maybe some of the botanicals or ivermectin. But if you're not doing those things, super important. And then you kind of have to approach it as an escalating treatment. So if you do those things, and let's say you looked at the stuff we didn't get to, like your, thyroid and other infections and mold and stuff, and you're dealing with that, and that you're getting better there, and you're doing some ivermectin and the other stuff, and you're getting better there, and you're getting resolution, great. If you're doing all of that stuff, and especially if you had a really high spike protein antibody level, then I would look at removal types of treatments, either, going in and donating plasma, as frequently as they'll let you do it, or doing a plasma exchange, because it's a real high level treatment, and it seems like, gosh, do I have to do that? Well, you don't have to do it if you're getting better, but if you're not getting better, you have to have a way to give your body a break and get, sort of take some of the load off, and those treatments are there for it. I think the other thing too is people get, with any chronic illness, but especially long COVID and spikopathies, you can get really sick and just feel like you're never going to get better. um, and the limitation on that is not so much that you can't get better from a spikopathy, long COVID situation, but it's that you have to put a lot more work into it than maybe a lot of other, illnesses that you're used to. And so working with people who kind of understand the chronic illness picture is very important. And that was a big reason that I wrote the review paper the way I did, is as you've seen when you read it, it goes all the way from, what is the problem and what do we know about it from the science, through how do we tell if it's a small, medium, or large problem, then how do we treat it? How do we escalate? So there is hope and there are answers. It's just not going to be real quick for a lot of folks.
Yeah. Well, thank you very much. This is incredibly valuable, and we thank you for your time and expertise.
Thank you.